Hello and welcome back to our podcast, What Now? On the Threshold of Life, Death, and Grief. It's great to be back in the studio, and I'm here today with my colleagues and friends.
Red Keating.
David Kennedy.
And I'm Julie Brown. And today we have a special guest, and Dr. John Beamish, who's with us. Thank you so much for returning yet again, John. We've had John in before, but we had some technical difficulties. So he's agreed to come back, and we're really grateful to have you here. So I just want to take a few moments just to kind of more formally introduce Dr. Beamish. So Dr. John Beamish completed his medical training at McMaster University and his family medicine training at the University of Ottawa. He's worked at many long-term care homes, been a champion for equitable health care. He's been a family practice physician for 39 years, and more recently has been our medical director at Hospice Peterborough. He's played an essential role in our community with our palliative care community team. He was recently recognized with an award for leadership and excellence, the Dr. S. Lawrence Liebrock Award for Palliative Medicine. He mentors new palliative doctors and provides local and provincial leadership in the area of palliative medicine. We're so happy to have you back in the studio with us.
It's nice to be back.
And I might just add, he's a good guy.
He's a good guy.
Stand-up guy.
Stand-up guy. Yeah. So to begin, John, could you just talk to us about what is palliative medicine?
Well, palliative medicine starts with the assumption that life is going to end. And that may sound obvious, but for generations, medicine was premised with the idea that you just kept treating and treating and treating and turned a blind eye to the reality that patients did die. And palliative care starts by acknowledging that reality and saying that there comes a point where the endless search for more time is not what's important to the individual, but what is important is the quality of that time. And so palliative medicine focuses on managing symptoms, be they physical, psychological, spiritual, so that the time that someone has left can be the time that they want it to be as closely as possible. So it is in a way revolutionary and has really changed how medicine is delivered in the Western context.
What drew you to it? And how long have you been doing it for?
Well, it's always been a thread through my practice of medicine. When I first graduated back in a long time ago,
just a while back,
there was no such thing as formal palliative care. It was an evolving field. So I practiced and worked when we didn't have adequate pain medication. We didn't acknowledge to even the patient that they were dying. There was a time where physicians were taught not to tell the patient they're dying. And you'd get into this charade where the patient knew they were dying, the doctor knew they were dying, but no one could talk about it. So things have come a long way from that time. I felt deeply uneasy with what I was seeing as a student and a young resident. And part of that was because my undergraduate training was not in the formal sciences, but was rather in psychology and literature. So I had an appreciation that sometimes life was more than just hard facts. And they needed expression, and how we expressed was important. So that I tried to work into my practice, and palliative care allowed me to do that. It allowed me to fill that need I had to be more than just a technician, but to try and relate to the person one-on-one as a whole person.
It sounds like it allowed you to be kind of more congruent with who you are and the way that you wanted to practice.
Exactly. I wanted to be part of people's lives. And, the end of life is one of two occasions when sort of the barriers between people come down. One is birth and one is death. And it's a very privileged thing to be able to be part of the birthing process or the dying process. And I enjoyed being inside that circle. I realized it was a very privileged position, and you realized you could make a difference. That was the other thing. Dying was done very poorly in many areas, and to be able to alleviate pain, to be able to help families heal, to help the individual heal, gave a sense of real satisfaction.
I recall when I worked at the old Civic Hospital in respiratory technology, that there was a group of people, Donovan Brown, I think, and a few physicians who were really, putting this thing out there. And I think that was the genesis of that in this area, in Peterborough. Yeah. And you were a big part of that from the beginning, John. But it had to be something that grew, because it wasn't something that was there.
Well, as with the whole evolution of hospice palliative care in Peterborough, it hasn't been led by the medical establishment. It's been led by the community. It's been led by people who saw the need and tried to fill that need. So just as you mentioned, I mean, Donovan was the chaplain. He saw the need. He gathered volunteers who would sit with people while they were dying. And that just sort of allowed everyone to stand back and say, there is this population that's dying, and we're really not meeting their needs very well. What more can we do? So it started with volunteers and then grew into professional protocols that would really make a difference in symptom management.
So it's interesting. How do you get that point across? I'm sitting here listening to it and, excuse me, haven't worked in it. But if I'm the person, quite often I think people have this concept that when I get to that point, I'm into that gray area and I'm moving away maybe from active treatment to something, and someone drops the term palliative care. And I think it kind of harkens to the title of our podcast is, what now? People often feel like they're just being dropped or let down by the medical establishment. And how do you communicate that to people that actually this is something different that they may not be aware of, but they're not going to be dropped?
Well, the good referral sources, and I think we're lucky in locally in Peterborough that the oncologists are very supportive of the work we do, and they see it as and they phrase it very well, that they're passing responsibility from themselves to the palliative care team. So it's not, they really try to avoid that sense of, well, you're being dropped. But they're sort of saying, on this journey, I've taken you as far as I can go with you. We're not at the end of the journey, and you need help getting the rest of the way. And that's going to be with the palliative care team. I think one of the things in palliative care we do that other physicians are uncomfortable with is we'll use the word dying. We will label what we see going on, and we strip away the illusion that things are going to get better, but talk about the reality that the road we're on ends with death inevitably. And really, we can't control that. What we can control is, how do you get there? How do you get from here to there? What are the landmarks you want to pass on that journey, and help people realize that?
Yeah, so I think that's important, that people don't feel forgotten.
No, it's very much a transition.
And it's active.
And it's active. And it's about establishing a relationship. And that isn't just a professional relationship. It's a person-to-person relationship.
I think that's the humanity part.
It's
of
the
it, right?
humanity part.
And
yeah.
we talk about that. Dying is not just a medical issue, and I think that's the whole idea. I love the way you keep referring to the palliative team, because it really is more than just a medical piece in this. It's the humanity, yeah. And that's a basis for all of us as we come to this point in life.
And I think good hospice palliative care allows the community to come forward and provide that care at the end of life. And that can be a formal community with nurses and professionals. It can be an informal community. But it's saying that this is the time to do that. It's sort of waving the flag and saying, this is the time to do that.
One of the things I've noticed as well, John, that's different about the way the palliative doctors interact with people is that you're really working with the whole family.
Yeah.
Like I've noticed that sometimes our doctors at hospice will have just as much of a relationship with some of the key family members as they do with the person that's dying.
Yeah. Well, one of the tenets of palliative care is that you're treating the patient and family. And I often use the analogy of when my kids were young, they had these mobiles that hung over the bed. And if you moved one part of the whole mobile moved. And I think that's the palliative experience. It's not just affecting the individual who's dying. You move that individual, everyone else that's on that mobile and in that family is going to be affected and moved. So our unit of treatment is the family as the individual defines it.
As they define their family.
As they define who their family
Yes.
is. Because, I mean, we've all learned that the traditional family is not always the family that steps forward or that the individual who's dying wants to step forward.
Yeah. It's funny. I was leaving hospice this afternoon, and it must have been 12:30 or so. And I met one of your colleagues walking in, one of our physicians, and I was back maybe about 90 minutes later, and they were coming out of the building. And when they were going, I'm just going to meet a new family. And 90 minutes later, they were done meeting the new family. And I thought, where else do you get a physician's time for 90 minutes, probably pretty much undivided, as an introduction to here, I'm your care provider. And I thought, that was actually really interesting to see. And she said, oh, it's a lovely family, and it was just that incredibly personal care and the time that's taken.
And from the physician standpoint, that 90 minutes was pretty rich. They gained a lot of knowledge about the internal dynamics of the family, what are the unspoken rules around how the family operates, and that knowledge will lead to better care in the time ahead.
What's going through your mind maybe in the background as you're meeting with a family like that? When you said like looking for the unspoken rules, I'm watching the way the family interacts. What kind of things are you trying to notice or kind of assess?
You're always trying to understand what are the unwritten rules of this family. Who is the person that really moves the family? And it's often not who you think it is. Who is the person I need to win over in order that this person will allow or receive the care they need? And it's interesting that can change over time. It can change depending upon the circumstance. It can change depending on the issue. One family member may handle everything to do with finance. So if you're talking about, transferring the person and they're going to have to pay for an ambulance ride, well, you better talk to them. Whereas another person may be the one you go to find out what are the emotional entry points for this patient. What are the things that helps draw them out? So you're trying to get a sense of the geography of the family.
What do you notice about people when they first meet you, when they first come? What are they asking the most? What's the questions that seem to be there?
Well, for many of them, they're struggling to come to grips with the idea that they're approaching the end of their life. So they usually start with, how long have I got? Anticipating that we have a crystal ball that we can gaze into. Having done this for many years, I realize how fallible we are. And certainly the literature backs that up. Physicians are horrible at guessing how long someone is going to live.
Sorry to interrupt. I was just wanted to mention is clients often think that you're withholding that
They
information.
do.
So many times
They
I've had to
just-
say, like when they say they don't, then they didn't give something definite. They don't have that to offer.
Yeah. And I will stress that with them because I know they think, oh, you just don't want to tell me that we really don't know. One of the interesting things is the determining factor of how accurate someone is varies by how much you like the patient. So the patients you like the most, you think are going to live longer. And I think that just tells you that physicians are human too.
Yeah.
We don't want to let go of the people we like.
Yeah.
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 That's interesting because that's the question that gets asked. Initial, how much time? If you give an answer, and people sort of set that in their minds as there's the date, that's the time. Yeah. If death occurs before that time, somehow they feel gypped.
Yeah.
That they didn't get the time that you told them they had. Yeah. And if it goes longer than that time, people can start to become really tired and get into a place of resentment that it's taking too long. And it didn't happen when you said, as you said with your crystal ball, the all-knowing doctor said. And now we're in this place where it's like, this is now laborious. This is now incredibly difficult.
Physically and emotionally and time consuming.
Yeah.
Or it's a badge of honor. I had one patient, I met him for the first time, or a client, first time I met him, he said, well, I'm well past my expiry date. Yeah. As if he had that as his badge of honor.
Show them.
So I think, and often I've come to realize that question of how much time I have, really what they're asking is, where am I on this journey? Mm-hmm. And the answer is to them, you have a very short period, you've got kind of a middling period, or maybe we've got longer. And they just want to know which ballpark am I playing in, because that's going to influence decisions that they make. It's a story going back to HIV and AIDS. But when all the young men were dying of AIDS, they thought they had a very limited time life left. And they would blow through all their money, take out loans, live the high life. Well, then along came the antiretroviral medications, and AIDS was no longer a fatal disease. And some of these guys had racked up incredible debts and had to declare bankruptcy because they never thought they would live. So, you're right, Red. We do, knowing which ballpark we're in influences decisions we make.
Mm-hmm.
What do you wish people would ask you?
I think I wish they would focus on how they can live or spend the time they have better. What are the things I need to do? And, the simple things are, ask for forgiveness, give forgiveness, say thank you. But how you play that out varies from individual to individual and life experience to life experience. But, and I think the palliative team tries to work on shifting the focus away from time and on to quality. What are you going to do with the time you've got?
That's a great way of putting it.
What are the ways that you might approach that in terms of providing, supporting the quality, John?
Well, and I think that I share this with my colleagues. We tend to speak bluntly but kindly, so that we lay out the facts pretty clearly, and then you challenge or ask people to think about what it is they want to do, what it is they need to do. One of the things I've learned the hard way is you can't do that in one conversation. You have to give the challenge and then give people time to reflect, talk to their family members, think about it. And then they'll come back to you with a plan. And then the challenge is, okay, how do we make that happen? Mm-hmm. And we've had amazing things. We've had weddings at hospice. We've had family reunions at hospice. We've had, times where people wanted one more trip to the cottage, and we were able to, orchestrate them getting up to the lake and then back to hospice. But they gave us the plan, and we then worked to make it happen.
What happens if somebody's plan, maybe I'll ask this differently, they're in a place of denial. So even though you're being clear but kind, they're kind of not, they're saying, no, that's not going to be me. Yeah. And they're still in the place of, really active denial. What then?
That's rarer than you think.
Mm-hmm.
It's truly not very common. Because if you listen closely, they often give you little hints.
Yes.
But if someone is truly in deep denial, despite our best efforts to sort of get beyond that, I think you have to respect that. They're in that denial for a reason, and there's something I don't understand that's getting in the way of them coming to grips with it. And I need to respect that and wait. Everyone gets there eventually. It's very, very, very rare for someone to die in a complete state of denial. And when it happens, it's often cultural. So they're in a culture that won't allow them to do it. But most people, it may be very late in the game, but they get there. They get there. And you have to respect, for whatever reason it is, they couldn't get there earlier.
I'm thinking about family conflict. I'm sure you've probably come across families in conflict, because, death can bring out, or dying can bring out the best in people. And it can also bring out some undesirable qualities in people, and how you manage dealing with families that might be the Hatfields and the McCoys, or find themselves on different divides in terms of what's happening, how it's happening, who's in charge, how you manage those kinds of situations.
Well, you really hope that the patient themselves can direct their care, because then you can challenge both sides of the family to say, we're doing this as according to however the patient tells us they want it done, and ask people to respect that. And I must say, most people do. No matter how much animosity is brewing, most people recognize this is a time apart, and we need to respect that this is almost a sacred time, and you don't bring your other stuff in. So most people are pretty good about it. If they're not, you challenge them and say, please, this is not helping. This is making things worse. There are very rare circumstances where you have to go beyond. If you think that decisions are being made that are not in the best interest of the patient, but are being done for a family member's benefit, sometimes you have to involve the courts. But, that's once a decade. It's not very often.
What about when the person is still pursuing maybe alternative kind of treatments? We all see that quite a bit. And of course, there's also a role for that, and we respect that. But when what you hear that they're doing, or maybe it's compromising their financial well-being, is not kind of congruent with what you are understanding the way this is unfolding. Yeah. What do you do then?
So everyone tries alternative medicines. I haven't met a patient who doesn't. I mean, it's a need they need to explore, and I honor that. That's okay. I just ask them to tell me, so that if there's potential interactions between what we're doing and what they're getting from their alternative medicine provider, we can avoid problems. And that works great. I also tell them that I will be honest with them. And many of the treatments that they're exploring, there's no evidence that it helps. But I understand their need to do that. I also tell them that there are many charlatans out there who take advantage of their vulnerability and will strip them of money and dignity, and they need to be careful. And they hear that. They hear that. So, but then if they're going to pursue it, that's what they need to do. That's what they need to do. So I never want to get into a head-butting contest, because that doesn't serve the patient well.
Yeah. And the theme that keeps coming up is this: we respect their process.
Yes. Yeah.
And it is a process.
And
if
it is
we
a
talked
process.
about, there's a growing awareness of this, and that comes differently for everybody in the family.
Everyone in the
and
family.
so, sometimes people think, well, if they've been given the diagnosis, then they understand. Well, no, that's just the beginning of that process. and trying to terms.
And you know, David, you make a very good point. Each family member gets there at a different time.
That's right.
And particularly around alternative medicine, you may have one daughter who really wants to explore it. The rest of the family says, nah, I'm not so sure we want to do that. And that's where you come back to, well, what does the patient want? What do they need to do?
Yeah.
This is hearkening back, I think, to our conversation about the vigil. We were talking about the bedside vigil, and all of this is going on in the background of the bedside vigil, and has been as a process. It's not just the last 10 hours. No. It might be the last 7 months or the last 3 months, or and all of this is, I think, creating space that allows everybody to get there in their own time.
It goes back to when the penny drops that death is coming, that the disease process is going to end their life. And then that's when the vigil starts.
Right.
Once that sort of recognition hits home.
Yeah, you're trying to clear the path so that people can come on the ride.
Yeah.
What are the biggest changes? I mean, think back to the infancy of palliative medicine, and I think what you said, you've been doing this about 75 years. Is that right?
Only feels like it, right?
What would you say are some of the biggest sort of changes or advances that you've seen over your storied career?
I think we are much more open as a society about talking about death and dying. You know, people like to say, oh, we're a death-denying society. Well, we were. I don't know that we're so much anymore. I think we've come a long, long way. You can bring the topic up and people don't run out of the room. So I think as a society, we've done very well. As a discipline, I think we've become really good at managing physical symptoms. We have a ways to go managing psychological symptoms. I think we still struggle as a discipline to help people in that sense. It's easy for a quiet patient to get lost in the hospital and their psychological needs met. So we've come a long way. But I think physical management of symptoms is light years from where it was 30 years ago. Our willingness and ability to talk about it has come forward so far.
Even the idea that palliative now is part of a rotation for new doctors and getting them involved. I was going to say, John, that I mean we're so fortunate here in Peterborough and Peterborough County. We have wonderful palliative physicians, and I'm just so taken with how young they are.
Yeah, exactly.
Now, that's my own age getting older.
Yeah, that's relative for us, David.
But what strikes me is, wow, these are physicians who choose to go in this at an early age.
Yeah.
What do you see the future of in palliative physician or palliative care?
I think it's very positive. I look at my young colleagues and they're smart, they're empathic, they're kind. Our community's in very good shape. Mm-hmm. And part of it is that they get exposure in their training. So in their medical school and then again in their family medicine residency, they will work on a palliative care team. And they begin to see what can be done to help with people's quality of life. Mm-hmm. And they feel drawn to it. And I think when I look at my colleagues, they're looking for something more than the straight scientific mechanics of medicine. They want that interpersonal connection, and they feel that makes them, that gives them satisfaction in their job, and it makes them a better physician. So they're looking for opportunities, and there aren't a lot in medicine, but this is one.
It's certainly, and we've talked about that. I mean, dying and death is a very sacred experience. You talked about it, the birth and the death. They both have this power about them, and I think that is true. I think there's a reality that strips away all the pretenses and things, and this is all the journey of our humanity. It gets put out there first, and so it can be a very meaningful, although difficult. I mean, so how do you handle? I mean, some of the challenges because death impacts you too. I mean, you
absolutely.
know, and that piece of working with people and they die, it affects you. And
absolutely.
So what's that done over the years? How have you learned to deal with that?
Well, I think you need to be cognizant of it, and you need to allow yourself to feel it. And you need outlets that take you away completely from death and dying. I'm fortunate in that I come from a family where no one else has anything to do with medicine. So when I'm with my family, the last thing we talk about is medicine. We're talking
Sports.
We're talking politics. Right. We're talking all kinds of things, but not medicine. Right. So I can get away and just put it down and leave it aside. And that's been a real blessing for me, that I can walk away and leave it. And I think you also, but you need to give yourself rituals and time to do your grieving. I do a lot of mine in a kayak, in the early morning on Anstruther Lake. It's a good way to sort of think through some of what you've gone through.
How has it changed you, or maybe developed you, or doing this work?
I think the biggest the change I noticed is I'm much less judgmental than I was when I was younger. And I've come to realize most people are trying to do their best. They may be clumsy, they may be inept, but they're trying to do their best. And I didn't realize that when I started this. I thought people were doing things out of meanness or mean-spiritedness. That's very, very rarely the case. It's usually coming from fear or anger. It's coming from a place of pain. So the suffering. The difficult behaviors you see in families and in individuals are coming from a place of pain. So I think, working in palliative care definitely increases your compassion and your patience with people.
I was just going to say, I hear patience a lot in what you're saying.
Yeah.
And part of that is in that theme we've had of respecting people's process. That's where we develop that muscle around patience too, right? That this is their journey, and the pace we move at is the pace that they move at.
That's right.
Not ours.
Yeah. I mean, one of the things in the early palliative literature that has created all kinds of trouble was Kubler-Ross's stages of death. And people interpreted those stages to be steps of death. And it created a certain rigidity, and for a long time trying to force people into this mold. Thankfully, we've moved long beyond that and recognized it is each individual's journey. And there are many phases that they'll move in and out of. And it's not really our job to try to move them in any certain direction, but trust the process that they'll get there.
I just keep hearing the theme of the physician as fellow companion almost versus the all-knowing expert. Even though you may be all-knowing, you may be very expert, have a lot of expertise in what you do, but that you exercise that expertise as a fellow companion versus sort of an above high, law top down kind of way.
Exactly, Red. I mean, I know a lot about managing symptoms. I know a lot about palliative care, but I don't necessarily know what that individual needs from my toolkit. And it's only by spending time with them and listening to them that I realize what it is they need from me.
I guess what I hear in all of this too, as we think about it, is, and I've heard this tonight, one of the gifts of palliative medicine is that if we look at suffering suffering is not the pain itself, it's the story that surrounds that pain. It's how people interpret what things go into it that creates that suffering. It seems to me that good palliative care takes time to understand that suffering. It's more than any other time in medicine when you go and see your GP, because I've got something here. They're not interested in that other piece of my life and that stress and all that. But palliative medicine has to make room for that if it's really going to do its work.
It does. And when it works well, we do it very well. But back to one of Red's earlier questions about, changes we've seen. We've become really good at managing pain. I'm not sure we've become so good at managing suffering. We still struggle with that part. And you see it all through the healthcare system. Nurses are tracked for the number of medications they give, not for the 10 minutes they sit at the bedside holding someone's hand. That is not deemed of value in our healthcare system. And we have to change that mentality.
Yeah, and I'm so glad you brought that back up, because that's been kind of, I've been wanting to circle back to that. What do you offer in terms of what you've learned around the psychological component of this? Like, how might you be showing up in a conversation with a patient, with their family around that? What does that look like, I guess, as I'm
I
asking?
think one is listening. So I model listening so that the family members realize it is about them and it is about what they want. I think I model acceptance that this is where we are on the road. And maybe reassurance that, you know what? Yes, it's going to be painful. Yes, there's going to be suffering, but it's going to be okay. Everyone goes through it. And I think that sense of you're not alone. You've got people who are going to walk the road with you, and they're going to help protect you and keep you safe and get you to the end of the road. I think that's what families look for, and that's what patients look for.
Big pause. As you were talking there, the thought that was running through my head was, it was back to that sense of team. That's what you do, and back to that question about a person feeling like, if I've been deemed palliative, it means medicine is done with me, and now I'm going to be left on my own. And I was today it was just sort of like, at our hospice anyway, our custodian and our chef are just key. You think about a team of medical professionals, and I would say two of the most important people on our team are those two people.
Absolutely.
And they bring that level of comfort and acceptance and just real humanity to their world and the people that they are with every day. And so I think that message, I think, is really important for people to hear, that you're not forgotten, you won't be left behind. In fact, you will almost be picked up and cradled if you're able to get yourself there.
Red, we admitted a woman today who's Chinese heritage. And as I left, in was going the chef to sit down with the family and find out, now, what are the foods that bring her joy? What are the foods that she loves? And how can we recreate that for her here? And I thought, there aren't many places that happens.
No, not many places in institutions where the chef comes and says, what would you like to eat? I'll make it for you.
Exactly.
Yeah.
And I think that's we talk about spiritual care as being that other piece of our being that needs a great deal of attention at this time of our life. And I remember when we were training staff, nurses and PSWs and maintenance and everyone else, and I remember making that point, saying, we all do spiritual care. That's not something left to an individual. Spiritual care is exactly what the chef did today, or what Mike does when he goes in, cleans the floor, and has a moment to connect with them. That's incredible spiritual care. So I think that's the other thing that we recognize the value of those moments and those things that people bring that really are significant.
And I think, back to Julie's question, part of what the physician can model to the other members of the team is it's okay to talk about those things. It's okay to express your own emotion. It's okay to have your doubts, that's part of being on the team, and we help each other through those moments. Learners, I think, are taken aback sometimes in palliative care by the permission we give them to talk about topics that in the rest of medicine they're not allowed to talk about. Your culture, how your culture interprets your experience. Those are not things that are talked about a lot.
Yeah, I was thinking, John, when you were answering that question about the psychological suffering, I was thinking, well, like, what do I do when I've gone into someone's home and I'm having that visit? And that word permission, I think that's a really big part of it, is giving people permission to and curiosity, like what is important to you, and let's have, and also like I can be with you in this conversation. Like this doesn't scare me. This doesn't, this is important to me. And I often find when I see like kind of a settling in the person, that a lot of it is just naming their internal process, naming if there's fear, naming if there's terror there, naming what are the fears. Let's name them, right? Like let's.
And Julie, I think that's really important that you're going in and you're saying, yes, you're afraid, but I'm not afraid to talk about it.
That's right.
And, you know, when you're ready, we'll have that conversation. But just know that I'm not afraid to talk about that. And that giving permission, often the anxiety comes down. You can just feel the anxiety drop in the room.
It's also, I've certainly witnessed, you know, being with people who, particularly often women who have spent their whole life looking after everybody else, and they come to this and we start to talk about, you know, what do you need for yourself, and they really struggle with that about, you know, how do I look after me, you know, because their whole life has been looking after everyone else. So it's often this real shift that and some may never be able to get outside of that. The whole thing is about others, but it is an interesting time.
It is, and I found, and this is my Catholic heritage coming up because I know Catholic guilt.
We just did a podcast on guilt.
but you can turn that on its head, and you can say to the patient who's holding people off at arm's length, you know, if you let them help you, you are in fact helping them.
That's right.
Because if they're involved in your care, they're going to have less guilt. They're going to have a better grief process. So in a roundabout way, by receiving care, by letting them care for you, you are in fact helping them.
That's right.
And that often, that sort of argument often is what breaks the ice and allows them to let a family member do more for them.
So we're going to start to wind up here. Any final questions that are?
I'll have a few when we're done.
It's not a question, it's just a comment. I'm so thankful, John, for your leadership in this over the years, and I know there were many that contributed to that, but I know you took a strong leadership in that. And I'm thankful for the gift that hospice brings in all of this. And we're not perfect, but I think the ability to confront this part of the journey of life, and it's part of the journey of life. It's, you know, I keep saying to people, it's not about death, it's about living until death. And this is part of our life. And how do we do that? So it's, and I agree, I think it is something that's becoming more talked about. And social media certainly has one of those ways that it is. We still have work to do, but I'm so grateful for the gift and the opportunity to have worked with you a little bit. So thank you.
To witness you leading with your humanity, right? And I think that's so rare to see in physicians. That's a horrible thing to say. Sorry, all physicians. But you know what I mean. I guess what we think when we're sort of non-medical people that sit back and think about the physician, we want their intelligence, but we can have that given, as you said, you know, when you approach a new family, with compassion. You know, and with understanding, and you can be expert, but you don't have to lead with it.
No.
You know, and if you can sort of gently insert those things and lead with your humanity, that's what I'm sitting back here just sort of reflecting on from the conversation, is that, and that's in all aspects of palliative care, that the folks that are there lead with humanity first, and they bring along what they do in their kit bag, as you said, and they pull out those tools when they need them, but the biggest tool they bring is themselves.
Yeah, I read that's so true, and it goes back to, you know, a theme we've talked about, that it's the whole team, that they lead with their humanity and they lead with their sense of welcoming and acceptance, and a good palliative care team does that.
I'm wondering if, as we finish up, I'm putting you on the spot. I know I did this in our last recording that didn't really record, but is there a story is there a story or something that you'd like to tell us that stands out for you in your career, or something that a patient or family has taught you about the dying process?
Well, we've talked a lot about team, and I'll just go back to that again. And about you never know who the true healing agent on the team is. And you just have to be open to that. And I think of one patient we had within the last year who was Indigenous. And he was rediscovering his Indigenous roots. Mm-hmm. And he had a ritual where he would light his tobacco and do a smudging every morning. Well, as he got weaker and could not do it any longer, the person who did it was the custodian. Mm-hmm. It wasn't a nurse. It wasn't a doctor. It was a family member. Mm-hmm. He chose the person who came in the morning to empty the garbage, but who always had a joke for him, who always said hello, who always made conversation. That's who he chose. Mm-hmm. So a good palliative care team is not hierarchical. Mm-hmm. It's opportunistic. Mm-hmm. And whoever the right person is, that's the person who does the task.
So lovely. Mm-hmm. Thank you.
Thank you.
Thank you.
Thank you.
Thanks so much for listening to What Now on the Threshold of Life, Death, and Grief. What Now is produced in partnership with Hospice Peterborough. Music by Paradise Garage. Technical support provided by Sean Heichert. What Now is recorded at the Thin Spaces Studio. You can find more episodes of What Now for free on most major podcast platforms, including Spotify, Castbox, Apple Podcasts, and Overcast. If you want to support us, please follow and leave a 5-star review wherever you get your podcasts. And please tell your friends. It truly does make a difference.